every time I see clinicians like Dr. Lin, I'm deeply grateful for the work they're doing, and I'm also incredibly frustrated that they need to do that. I would like medicine to be a place that allows us to do what we were called to do, and where patients can feel that. This is not a problem that started in the pandemic. Before the pandemic, 43% of healthcare workers had at least one symptom of burnout. They were exhausted, and they felt ineffective. They were cynical or detached. And when I started talking to folks about it, what I heard almost everyone say was, I don't have better language for this, but there's something about it that just isn't right. And so, I started asking why. What really is happening here? And I talked to Mary Franco, who's in chapter 3 of the book, and she's a nurse practitioner who said to me, I'm done. I'm retiring 3 years early because I can't stand the fact that we've been bought out by our hospital, and I now have 10 minutes less per appointment with my patients. I can't decide who is appropriate to my skill set, and I can't even look them in the eye. This is not the way that I think it's safe or good for patients for me to practice medicine. So she left. I talked to Rita Gallardo, who's in chapter 7, who said she quit 2 jobs within 5 years because her hospitals were telling her where she could refer her sickest cancer patients. And she said, I did not come here to make sure that my patient revenue stays within my healthcare system. I came here to make sure my patients got the best care. And then Keith Correll, who is featured in the New York Times article today, who basically said, my hospital is undermining my medical judgment and inflicting financial toxicity on my patients in the ER. None of that sounded to me like too many hours, too many tasks, too much administrative burden. That sounded to me like there's something fundamental happening at the core of healthcare. And so, of course, there are the usual burdens that we talk about that are the operational challenges of medicine. But again, that isn't what clinicians were talking about. Isabella Rodriguez, who's in chapter 5, practices in Western North Carolina. And she summarized it best when she said, I spent 25 years of education and training learning what the gold standard of care is. The second I walked out into practice as an attending, I had to compromise that gold standard of care. I knew I was signing up for long hours, for seeing impossibly hard things. What I didn't know was how hard it was going to be to take care of my patients, and that's what breaks my heart. She was saying, I made a promise to care for my patients. I learned how to do that to the best of my ability. And my hospital, my healthcare system, the choices that we make that our legislators make for us have tied my hands. She was beginning to wonder if she could still be a good doctor practicing the kind of medicine she was allowed to practice. And at the root of that practice of medicine is the corporatization of care, where gradually over the course of decades, starting in the mid-1980s, control of healthcare has moved sort of relentlessly away from the control of physicians. It is now big business, and physician voices are practically drowned out. For every physician practicing in healthcare, there are 17 others. Only 6 of them touch patients. It's not hard to imagine how hard it is to shout loud enough to not get drowned out by those 17 other voices. I'm sure almost all of you have seen this graph, which just puts a finer point on how much administrative oversight in healthcare has grown. The bottom line is physicians, the growth of physicians, which has pretty much kept pace with population growth. And the red line is growth of administrators. It's true that it's driven, at least in part, by additional regulatory burden, but it has gotten to the point where it has begun to control how healthcare is practiced. What's gone along with the corporatization of care is consolidation. So these are the mergers and acquisitions up until 2017, prior to the pandemic. There was a pause during the pandemic, and it's opened back up again. But what we're seeing is that many locally controlled hospitals have now been consolidated into major medical centers. When that happens, the layers between those on the front lines and those at the CEO level who are making the decisions get deeper and deeper and deeper. So trying to ask for a change through 8 layers of people who can say no to your request is exhausting. And this is what's happened to community hospitals. They've also been largely consolidated, so that no longer do we have community hospitals controlled by community boards, excuse me, taking care of neighbors, making sure that the patient stays at the forefront. The clinicians' concerns are increasingly less at the forefront than the financial health of the hospital. And it's easy to understand that when you're operating at margins where they were in 2005, when they're between 1.5% and 2%. But over the course of the last several decades, as we've gotten to consolidation, operating margins have largely increased. We're now at 6 to 7% in a lot of hospitals. So that relentless push for more margin isn't necessarily necessary, but it's coming at the cost of the patient experience and of clinician well-being. This is a fantastic book that I think everybody has got to read. So Lawton Burns is a management consultant and David Dranov is an economist. And they go through what Big Med has done to healthcare. And they really clearly lay out what are the empty promises that Big Med is based on, that all the consolidation is driven by. And those promises are care coordination, which we all know hasn't improved. Population health, that if we can aggregate the data and if we can take care of a larger population, then we will do better. That has not proven out. Quality of improvement hasn't proven out, nor have economies of scale. And we all know that as healthcare organizations consolidate, they drive out competition and they don't lower cost. What this has led to is a divided house of healthcare, excuse me, where we have administrators on one side who have an obligation to the organization. If it's a for-profit healthcare corporation, they are beholden to their shareholders to increase the value to shareholders. If they're in a nonprofit organization, they're still held to increasing revenue. On the other side, we have clinicians who have an obligation to the patient. Those obligations don't always align. And that's where the challenge for clinicians come in. When we're being asked to attend to the needs of the organization over the needs of our patient, when we made a promise to society that we would care for patients as our priority without any attention to our self-interest. That doesn't mean that we should be selfless in the extreme. What it does mean is that we promised that we wouldn't make outsized profits on our patients. So as I was thinking about all of these, Simon Talbot and I came up with this, we heard about this concept called moral injury that was applied in the military context. And we heard that drone pilots were experiencing moral injury. Drone pilots never see actual combat. They go from their houses in suburban Nevada to the military base. They fly their drones, get back in their car, and go to their families. They were experiencing this. And I thought, if a drone pilot who never sees combat can experience moral injury, I bet it's happening in healthcare. So I started looking into it. And the first person who wrote a definition was Jonathan Che, who was a psychiatrist working with Vietnam veterans. And he said he believed it was betrayal of what is right by someone who holds legitimate authority in a high-stakes situation. All those three things had to be in action. I would say in healthcare, we have all three of those. What then happens is that faced with that betrayal, we have a moment to decide. Will we stand up and speak out? Or will we transgress our deeply held moral beliefs and expectations, which are the oaths that we took to put our patients first and increase our risk of moral injury? So when I started thinking about what the relationship was between burnout and moral injury, it's not that it's either or, it's both and. These things coexist. And we're actually seeing research that's coming out that actually defines that. Burnout is one condition, moral injury is another. They often run together, but not always, and they can influence each other. So moral injury that's unrecognized and unattended can get to the point of burnout, where people just have that learned helplessness of giving up. For those resource demand mismatches that we keep speaking up about and aren't addressed, when that's ignored repeatedly, that can start to look like a betrayal and feel like a betrayal, and that can feed into moral injury. So it's both and. We can't just address the operational aspects of burnout, reduce the administrative burden, make the EMR better. We also need to attend to the relational repair that is required after this perception of betrayal. So Simon and I published this article in Stat News saying, let's do a thought experiment and see if anybody else thinks the same way we do. We expected that it would get tossed in the pile of other literature on burnout. And so it was shocking to us when there was a deluge of response. So it has been downloaded 300,000 times. It was the most read article in Stat News in 2019, even though it was published in 2018. And it's still, 5 years on, one of the top read articles for the publication ever. And this isn't because we're so clever. It's because clinicians were hungry for a new way to explain what was happening to them. They needed to explain this existential crisis of saying, this is not what I signed up for. And this really gets at the heart of the promise that I made when I entered this profession. So what are those betrayals? When we hit COVID, what it did was to stress test the hospital and healthcare systems. And it highlighted in stark relief all of the things that healthcare workers had been shouting about for a long time. And what they talked to me about, I heard all of these different quotes, but what they talked to me about were betrayals by their hospital leadership who said, oh yeah, it's fine to reuse N95s. Their governors who didn't institute mask mandates before there were vaccines. State agencies, federal agencies who relaxed safety standards when it was clear that healthcare systems wouldn't be able to meet them easily. By the media, who polarized things like vaccination and masking. By our patients who wouldn't do the smallest things to care for their communities and still came to us expecting to be rescued when they were in extremis and putting us at risk in the process. Ed Yong put it really succinctly in his article in The Atlantic in November of 2021. He said, healthcare workers aren't quitting because they can't handle their jobs. They're quitting because they can't handle being unable to do their jobs. Death became very present for all of us in the midst of the pandemic. And in the midst of that, we started reordering our priorities. We started wondering, can we work for organizations that treat us as they have, that treat us as expendable? Now, I do want to make one quick note here that administrators did feel moral injury. More of them who have been clinicians in the past, but overall, administrators in the pandemic, about 40% of them experienced moral injury. So it's not just unique to clinicians. And that, for me, is a point of commonality where we can start to make change. But it's not individual change. We're all resilient. We all know how to keep our high performance selves tuned. We know how much sleep we need and how much exercise we need, how much yoga we need to do to optimize our function. But when you put us out on potholed roads, it's no time before we're in a ditch or have a broken axle. We need to fix the roads. With moral injury, there are a few places where we can intervene. At that first hint of betrayal, we can say that, the person who betrayed can recognize that and repair the betrayal. If we say to them, hey, not cool, they'll say, okay, you're absolutely right. That was not my intention. Let's go back and repair that. Because for the most part, betrayals are unintentional. The other place that we can intervene is to speak out and resist the betrayal. And that's where we can really make an impact. And that's where organizations like Take Medicine Back, like Moral Injury of Healthcare, are equipping folks to do that. We need to start rebuilding our communities that have been devastated. We need to stick together to do that. We need to speak out. This is part of why we're seeing more and more interest in unionizing, because it's not safe to speak out alone, but in a union, you almost never do that. You have a collective voice. There are other ways to get that collective voice, but we need to start seeking that. And finally, we can start looking for new processes. We have been talking in medicine for a long time about the errors that we make, but let's start talking about the threats that are outside of our influence that also impact our patients' experience, their safety, the things like, the administrative challenges that we face in getting patients care. What about doing administrative M&M once in a while? We can take local action. We can start educating our legislators about what the real challenges are that we face day to day, because it's hard to know medicine unless you've been in it. So the more we can explain, the better off we'll be. We can take state level changes like the Lorna Breen Foundation is doing in changing the language around relicensing and mental health issues. And we can take action at the federal level. I know a lot of people wrote in about the FTC non-compete clauses. There's now legislation proposed for protecting healthcare workers against violence. We need to be asking for more legislation and supporting what's proposed. And finally, we need to ask for morally centered organizations, those that are wise and learn from their mistakes, that are human and vulnerable, that are trustworthy. They do what they say when they're going to do it. They have our backs. The ones that are intent on developing the next generation of leaders, mentoring for real, and that are just and courageous. They ask for feedback. They tolerate that feedback even when it's hard, and they push back themselves against legislation or regulations that they know will harm or be difficult for their employees. Throughout the pandemic, we were sort of isolated and on our own. And I think we're now at a point where we're starting to see the end of the pandemic, and we have new language for the distress we're feeling. And so I hope that we're seeing the end of this one crisis as a new beginning with new language. And here are the resources that are available. Our website for the organization, a podcast with more than 60 episodes, and the book that Mitch mentioned. Thank you very much.